This is Dr. Howard Strassler with the hints from Howard on bioactive materials, and our focus today will be fluoride-releasing materials for the high caries risk older patient. We're currently seeing changing demographics with an older population. In fact, by 2030, 19% of the U.S. population will be 65 years and older, and by 2030, 2.3% will be over the age of 85. Currently, the fastest growing demographic of patients that we could possibly be seeing is over 100. And then we look at current assessments. There's a root caries prevalence in U.S. adults 65 years and older at 14%. Among racial minorities, that prevalence actually increases to 30%. Along with that, among our older populations, we're seeing more adults with chronic medical condition, and in fact, we're seeing compromises in access to transportation that hinders access to dental care. We have more adults, older adults, who are unable to get to the dental office, and these are adults living independently in assisted living facilities and nursing homes. How are they going to have access to dental care to maintain their restorations, to maintain their teeth? In fact, we're seeing an increase in root caries among these high-risk caries risk older patients due to the fact that we've done such a good job, they're maintaining their teeth over their lifetime. We're seeing with the maintenance of the teeth accompanying gingival recession. Along with that, since many of these patients had sought regular dental care, by keeping their teeth, we see more crown and bridge, single crowns, and bridges. In fact, in the last decade, there's been an increase in implants to replace these missing teeth. But all the teeth, natural teeth that are being kept, are at risk for cervical caries. In fact, these high-risk older patients, when you look at replacement versus repair of existing prosthodontic restoration, that we're seeing caries and difficult to prepare and access intraorally due to saliva, blood, they're subgingival. We see that in our decision making for replacement of existing crowns and bridges, that we see the challenges to the decisions as to whether to repair or replace patients who have fixed income. The cost is out of their ability to pay. We're seeing once again access to dental care. Their living circumstances are making it someone else's decision to whether they can have access to transportation for treatment. So how are we going to treat these patients with these teeth that are at risk? Well, one of the things that we've seen available to us are bioactive dental restoratives, and the definition of bioactive dental restoratives are restorative materials that form a surface layer of an apatite-like material in the presence of an inorganic phosphate solution. We also see restorative materials that are fluoride releasing and are remineralizing of at-risk teeth to caries. And among these bioactive materials are materials for treating direct pulp capping and endodontic perforation, those apatite-forming materials, and bioactive materials that are placed as restoratives for the high-risk caries patients, the glass ionomer cements that we have available as restorative materials. So let's take a look at bioactive fluoride materials. Certainly, all our topical application fluorides, the acidulated phosphate fluoride gels and the neutral fluoride gels, are bioactive. Fluoride varnishes, silver diamine fluoride SDF materials. We also see our direct restorative materials that are tooth colored are resin modified and conventional glass ionomer materials. And so we're seeing these older patients at risk for clinical caries. To our right, we see that the presence of an existing crown with recurrent decay, or exposed root surfaces in difficult to access areas having caries. We're seeing caries at margins of existing restorations that we're picking up uh, during routine radiographic clinical examination. And so these at-risk caries areas, how are we going to restore them? Are we going to be using composite or are we going to be using glass ionomer? And so difficult to access caries, less extensive treatment choices where placement of composite is impossible because of blood, hemorrhage, saliva in difficult to access areas subgingival. Areas that are difficult to repair because the patient can't afford a new crown, a new fixed bridge. And so when we look at surface treatments for caries, we have the choice of surface treatments for caries using silver diamine fluoride, SDF. We can restore teeth with fluoride release with glass ionomer cements. And these are our treatments for repair, for difficult to access, for when treatment decisions are difficult for patients. So when we look at bioactive remineralizing caries reduction, we look at silver diamine fluoride for caries prevention and arrest in children. And it's been successful. Our systematic reviews are showing that this is a good treatment choice for primary and permanent teeth. We can extend the use of silver diamine fluoride for older adults, and that they're effective in their application for caries management in older adults. And it's certainly a clinical decision choice, especially for the patient who's having difficulty to get to the office, can't sit for long appointments because of medical conditions. That we can use glass ionomer cements that's been clinically proven that these are fluoride releasing and remineralizing, that they have antibacterial activity. The fluoride release and fluoride uptake of these materials help reduce the recurrence of caries around those margins of existing class 5s and around the margins of existing crowns and bridges where we've been doing repairs with glass ionomer. And the benefits of glass ionomers, they're self-adhesive, they're fluoride releasing, there's a reduction in recurrent caries, they're well suited for these high-risk caries patients, they're good and great to use in difficult to access and isolate areas. Glass ionomers are moisture tolerant. In fact, think about it, the distal of a second molar where it's slightly subgingival, using a round burr to remove the caries and then going in and restoring it with either a self-setting or resin-modified glass ionomer. If you can't get a light to an area, then self-setting conventional glass ionomer cements are a good choice. Silver diamine fluoride is a good choice. Now keep in mind, after initial application, that you'll need to do an application every 3 to 6 months. For this 65-year-old cancer patient with xerostomia and cervical caries, that without removing the caries at all on these root surfaces, we're painting in silver diamine fluoride. And these are different approaches. Yes, they leave the surfaces black, but for patients where there'll be difficulty getting in for treatment, these are reasonably minimally invasive in terms of no need for anesthesia. So at medical risk, we're not really doing anything more than painting these on the teeth. In fact, the CDT procedure billing code is per tooth, using code 1354 for interim caries arresting medication application. So SDF is arresting the caries, although like I said, every 3 to 6 months we're doing a reapplication of this material. For restorative treatments, we're looking at using glass ionomer cements In this case, we're using to the carious area on these root surfaces and very difficult to access area, we're using chem-fill rock, a conventional glass ionomer cement that's self-setting. And one of the reasons I like chem-fill rock, even though it is very white and opaque in these areas, is I don't need a pre-treatment and I don't need to cover it with a varnish while I'm allowing it to set. We can also treat with a more aesthetic glass ionomer that's resin modified, here restoring these root surfaces for an older adult with Ketak Nano. And here we're worried about that we're slightly subgingival. Fortunately, we have no hemorrhage, but in areas of hemorrhage and a little bit of saliva, resin modified glass ionomers work quite well, and they're self-adhesive. I don't need to worry about etching enamel. That I use a cavity conditioner followed by application of these resin modified glass ionomers. Or for the patient who's undergoing chemotherapy and is at high risk with significant root caries. For this patient, using Fuji 2LC from GC America to restore these surfaces. While not as aesthetic as composite resin, we know that this patient has multiple surfaces and that this patient is at high risk of recurrent decay. These glass ionomers will reduce the recurrent decay around these gingival margins, these high-risk root surface margins. Now, this was Howard Strassler with a hints from Howard on bioactive materials that are fluoride-releasing materials for the high-risk caries risk older patient, using both glass ionomers and using silver diamine fluoride for treatment of these high-risk areas.